Hello everyone, welcome back to the Improving Flow stream of the conference. You're lucky in that we've actually got 3 speakers for our next talk. Our next talk is 25 minutes. Before we introduce them, just a little bit of admin again to remind you, we've got the attendee chat. Please do use that just to drop back feedback, comments, thoughts, reactions. But most importantly, we've got the Q&A, and we do have time for Q&A. So if you have any questions for our speakers, please do pop them in the chat, and you can upvote them, and I'll be asking your questions to our lovely speakers at the end of their talk. So like I said, we've got 3 speakers for this session. They're all from Northumbria Healthcare Foundation Trust. We've got Richard Bilsborough, Fabian Bagan, and Chris Wilcoxon, and they're going to be telling us about building and implementing a patient non-attendance prediction system using commonly available data. And here they are on screen, and we can see your slides. That's brilliant. So over to you. Thank you all.
Perfect. Hey, I'm
Oh, we do seem to have just lost Richard. Chris has got the slides. I don't know if you guys want to introduce yourselves, and we will backstage see if we can get Richard back on.
Great. Go for it, Fabian.
Oh,
I'm Fabian Beigang. I'm a data scientist at the Trust at Northumbria.
I'm Chris Wilcoxon, Public Health Analyst at Northumbria.
and I'm Rich Bilsborough. Am I here? Am I live now?
Yeah.
Perfect.
Yes,
Right.
you're live.
Good. Okay. Right. So our project was kind of an applied data science project on predicting non-attendances in endoscopy. Can we have the next slide, please? So just as a bit of background, our trust covers both Northumberland and North Tyneside. So it's kind of, if you imagine where Newcastle is, we don't cover Newcastle, we cover everything to the east and up to Scotland. So it's quite a varied patch. There's a lot of parts of it are quite rural, parts of it are basically Newcastle, very urban. One of the services we offer is endoscopy. We've had a bit of a problem with DNAs there, so we lose about £300,000 a year in lost revenue and then costs on top that we also lose. Obviously, that also affects the patient. If they don't turn up, they're still going to need the diagnostics, but they're getting worse all the time. They're deteriorating. So our project was to create a way to a data model that can predict which patients are or aren't likely to DNA, and then put an intervention in place for somebody to contact the high-risk patients and try and hopefully get them into the hospital. Next slide, please. So we'll be looking at the data sourcing. Fabian will be taking you through the actual analysis and how the model works. I'll be showing you the front end of the tool that we built, and then Chris will be telling you about his side of things, which was the actual doing the work with the patient side of things. Next twice, please. So the first part you need to do with any data science project is get some data, right? For this one, our main source of data was PAS, so our patient administration system, that has all the appointments on it. For the training data, we obviously had all the outcomes on it. That's at both spell and episode level, so you can do things with that. We know everything that's related to referrals is in there. For the past ones, we can see clinical coding things, which we messed around with, but didn't quite work very well for this one. For other ones, it's worked a bit better. Obviously, demographics, which you can tie, as you can see down there, to IMD, nursing home, whether the patient's a prisoner, the distance between the hospital and where they live, things like that. We also pulled a few bits from Icarus, which is a clinical system. They didn't get used in the actual model. They're just straight to the front end. It's more contextual type things, to be honest. We did play with linking it to Epicure. Again, that didn't particularly add anything, so we didn't use it for predictions. And fingertips can be added. We've not really messed around with that yet, but it's very possible to do. Next slide again, please. So the whole data source creation cycle, and Fabian will kind of explain this a little better because of how it works. What happens is, the best way we found to do it was to build a small data set, send that over to Fabian to do the actual modeling and work out all your relationships, all that. Meanwhile, I'm adding extra things, taking bits out if they're not useful, messing around with maybe certain variables are better as a series of booleans rather than something else, or there's certain outputs that are just wrong. Maybe you want to populate nulls with a value, something like that, whatever's going on. So it's a very kind of iterative process rather than a one and done, and that was much better for me, and I think for Fabian, to kind of stay on top of it and not be just overwhelmed by everything all at once, because there's, as everybody knows, there's an awful lot of data around. Fabian?
Right. We get the next slide. Right, so yeah, I'm going to talk a bit about what we found in analyzing the appointment data and how we use that to build our non-attendance risk stratification model. So after cleaning the data that Rich just outlined, we ended up with around 39,000 endoscopy appointments for a time period of 2 years, from 2022 to 2024, which was collected from 5 different sites in the trust. Next slide. Cool. So the overall non-attendance rate for those 2 years for endoscopy appointments was 3.9%, and that's after excluding cancellations. And in the data, we found a number of interesting patterns, and a few of those I quickly want to share with you. The first one is the correlation of non-attendance in endoscopy with previous non-attendances. As you can see in the chart to the right, there's a strong correlation with non-attendances in the past and missing an upcoming endoscopy appointment. And so here we did look at all types of hospital appointments, and we were looking at the past 2 years. And generally, while this might not be terribly surprising, obviously past non-attendances might be indicative of future non-attendances, I think it's still remarkable to see how almost linear this correlation is, and that, with each additional missed appointment in the past, the likelihood of also missing the upcoming endoscopy appointment increases. And then next we have deprivation, measured using the index of multiple deprivation score. And again, we see there's a strong correlation, almost linear, and generally going in the direction that the higher the level of deprivation of the postcode that a given patient is registered at, the higher the non-attendance rate. And then lastly, an interesting demographic observation. So if we split the data by age groups and by gender, we obtain groups that have very different behaviors around attendance. And just to pick out the most extreme ones, for example, male patients in their 30s have roughly 7 times the non-attendance rate that female patients in their 60s have. And yeah, so, that's just a few examples of things we found. And I guess that shows that there clearly are different patient subcohorts that have very different, non-attendance risk profiles. And those types of insights we then used to select variables to go into our risk stratification model. And so next slide, please. Cool. Right, so I'm going to skip over the technical details and explain this at a relatively high level, but feel free to ask any questions in the Q&A later on. But so the general aim of our project, of that part of the project, was to build a supervised machine learning model which estimates the probability of a patient not attending their endoscopy appointment based on patient characteristics and appointment characteristics. And so the probability of not attending was what we then considered to be their DNA risk score, or their non-attendance risk score, which is kind of one of the central concepts in this project. And so the way we use the historical data is kind of the standard machine learning methodology. So part of that data we use to train the model, which means to fit the model parameters to the data. And the other part of the data we use to test the model. And it's always important to test machine learning models on data that was not used to train the model in order to obtain an unbiased estimate of the model's performance. And the way that usually works is that we pretend for a moment that we don't know the outcomes for the patients in the test data set. Then we run those patient and appointment characteristics through the model to obtain the risk estimates, to then compare those risk estimates with the actual outcomes. And so we tested a bunch of different models and different parameter settings. And if we go to the next slide, we see that the model that ultimately performed best was a model called XGBoost. And so in evaluating machine learning models, it's quite important to look at different evaluation metrics. And for every type of machine learning model, there's different evaluation metrics that are kind of appropriate to the aim of the project. I'm just quickly going to talk about one of the evaluation metrics that we looked at, and the one that I chose is calibration, because I think calibration has a relatively intuitive interpretation to it. So generally calibration, or in our case, calibration means that for each patient group within a given risk bin, we would expect the average assigned risk to that group of patients to roughly correspond to their observed non-attendance rate. And to see what that means in our specific case, can we go down 2 slides, Chris? So here in this chart, we can see the different risk groups. On the very left-hand side, we have the patients with the lowest risk, namely all the patients that were assigned a risk between 0 and 2.5%. That's all in all 3,700 patients. And then if we look at the observed non-attendance rate within that group, we find that they have a non-attendance rate of just 1%. And then on the other extreme end of the spectrum, we have the high-risk patients. That's all the patients that the model assigned a 10% or higher risk of non-attendance to, which is a much smaller group. That's only 500 to 600 patients. And in that group, the observed non-attendance rate was almost 20%, right? And so I think that's fairly strong evidence that the model is quite good at identifying different groups of patients that exhibit very different risk profiles. And, in this case, we can identify a group of patients where we would expect only 1 in 100 to not show up to their endoscopy appointment. And on the other hand, we have a group where we could reasonably expect 1 in 5 to not show up to their appointment. And yeah, the last thing that I quickly want to mention is, if we go to the next slide, explainability. So for us, it was quite important to not have a model that just spits out a number, but to have transparency. And we tried to achieve that using a method called SHAP, which basically breaks down a risk prediction into the individual contributing factors that led to that risk assessment. And which can maybe show what that looks like on the next slides. And with that, I'll pass it on.
Exactly. That's exactly I looked at that. We did.
Cool. Can we have the next slide then, please, Chris? And again, okay. So at this point in the project, I've created a big historical data set and given that to Fabian. Fabian's then used that to train a model which can then predict, given the factors that he's found are significant, he can then predict, if we give him a patient's details, whether that patient is likely to attend or not. And it gives us a risk between 1 and 100%. Now we need to transform this into something live, which Chris then can then use. So to do that, I use, it's not quite as easy as this, but it basically is. We changed the dates on this old data set to pick up the future appointments for the next couple of weeks. And then we build some pipelines to take all this data from our on-prem servers, so the back of PAS basically, drop that onto the cloud. That then pops the data up into Fabian's machine learning endpoint and back down, so that we have the patient's details with the risk attached. Then they go into some tables that Power BI reads and shows us a nice front end, which looks a bit like the next slide, hopefully. Yes. So you can see here, this is the kind of first screen that Chris will be using. So we get by day how many patients there are on each day. And then you'll see the table below that graph there. So each trust ID is each person, each row is each person. We have 2 patients there that are, their risk is in red. So there are 2 patients who would be calling because their risk is above 10%, which was just a number we agreed on that gave roughly it gave enough patients for Chris to ring in a day per day. There's also some other attributes. So whether the patient is a current inpatient, if they're on premises, we ring the ward they're on rather than the patient themselves. If the patient has recently DNA'd a previous appointment, could you just go to the next slide, please, Chris? And then, yes, whether we think the patient is a prisoner or not is in as a filter, because regardless of the DNA risk, we need to contact them anyway to arrange the transport with the prison, all that sort of things. It's outside of the scope of the model because they just need to be contacted regardless. Next slide, please. Yeah, so we have another page here. So the grid down in the bottom left is the output from Fabian's SHAP model. So that gives each patient's breakdown of the internal weightings, if you will, of why we think this patient is or isn't going to attend. Up in the blanked out bit there with all the patient's contact details, so Chris can call them. And then next slide, please. And then, yeah, we also pass some wider bits of information that we know about the patient, any comments on Icarus, any flags on PLAS about whether the patient's in a wheelchair or whatever, and any other upcoming appointments in case there's a clash. Next slide, please. Yeah.
Great, thank you very much. So my role in all of this was to project manage the implementation of the health navigation side of this. So after the patients have been given their risk scores, someone then needs to actually do something with those risk scores. So it was my job to make sure that happened. And so for the duration of this project, I was also acting as the health navigator. So on any one given day, we would take the Power BI report that Rich just showed you there that had all of the patients whose appointments were coming with the risk scores from Fabian's model. So we would identify those high risk appointments using the Power BI model. Obviously, every patient there you could see with a red risk score. They were the ones that we were calling. So we'd identify those appointments, and then we'd actually try and understand the patient barriers to attendance. So you could see the SHAP model that Fabian and Rich showed you there. It would actually give some indication as to why that patient had a high risk score. For a lot of patients, it was previous non-attendance behaviour, but it wasn't always. And so a quick glance at that would allow us to understand what particular barriers any one patient might have for attending their appointment. And then we would intervene with a check-in phone call. So we would go into the patient details page that Rich showed you there, we'd take the patient's phone number, and then we would give them a ring. And the whole point of this check-in phone call really is to ask some key questions. So will the patient attend? So we'd introduce ourselves, say why we're calling, and make it very clear there was nothing to worry about with this call. We just want to check if you're aware of this appointment and if you'll be able to attend. We'd ask the patient if there was any barriers to attending. So that could be transport, that could be anxiety or worry about the appointment. It could be difficulty getting time off work. Could be anything. We can't always do something about those barriers, but it's really good intelligence for us to find out what those barriers might be. We'd ask if the patient needed to reschedule, which they quite often did need to do, but often patients who need to reschedule just won't call us. So this phone call acted as just an extra point for that patient to get in contact with us and change their appointment if they needed to. And then we'd ask them if there's any additional clinical support necessary. Obviously, I'm not clinically qualified, so I wasn't able to give that support over the phone, but every patient who it was deemed did need some additional clinical support received a phone call back from one of our endoscopy nurses. The whole point of this phone call then really was, what can we do now while we've got this patient on the phone to make sure this patient attends? So the project activity, once obviously we'd got all the calls done, we made 865 outbound calls for 609 distinct appointments for 515 unique patients. Obviously, some patients there were having more than one appointment during the duration of this project. We made an average of 11 calls a day between October the 10th, 2024 and January the 22nd, 2025. We had a 79% contact rate, so 4 in every 5 patients we were actually able to get through to. The calls were pretty short, really only 3 to 5 minutes. I think that the longest call was about 15, maybe 20 minutes. Some calls were over and done within under 2 minutes. Some patients felt like they didn't need any support at all. It was, yep, I'm coming, no problem, see you there. Some patients needed a little bit more support. We did do a feedback survey for some of the patients that we contacted, and 88% of those patients who filled that survey in said that they found the call helpful. We found it was really, really important to call from a real phone number. And I'm sure everyone on this call has had phone calls from unknown numbers and completely ignored them. We had to make sure that we were spoofing really a real local phone number. We've done health navigation before where we've used a kind of a generic phone number that isn't the local number, and the contact rate was a good 30 percentage points lower. So if anyone else decides to implement this, it's really important that you've got a real phone number. The patient profile, very quickly. So you can see this is the age distribution of the high risk and the low risk patients. Obviously, we were only calling the high risk patients, but you can see there, echoing Fabian's charts from earlier, that the high risk patients had a much younger age distribution, as we would expect. And we can also see that the IMD distribution, this is quintiles, not deciles, unlike shown previously. You can see that the majority of patients who were in that high risk group were in IMD quintile 1 or IMD quintile 2, again reflecting the non-attendance risk and how that correlates with deprivation scores. So very quickly, some of our project outcomes. We expected to see a non-attendance rate of around about 17% in the high-risk population. And these were our observed non-attendance rates during the lifespan of this project. So for the people we successfully contacted, we achieved a 4.9% non-attendance rate. So that's much lower than we would have expected based on, when we looked at the risk bins that Fabian showed earlier, 4.9% is much lower than we would expect for this high risk cohort. For the people who we couldn't get in touch with, it was 40.5. So there's something really important there in that the people who we can't get in contact with, it's not just that not answering the phone has some correlation with not turning up to an appointment. There's clearly some data quality issues there around the phone numbers and the contact details we have for those patients. That non-attendance rate is too large to just be down to people not wanting to come to an appointment. There's clearly some issue there that these patients might not know about their appointment. And so there's going to be QI projects that come out of this around trying to improve our data quality around getting in touch with patients. Overall, for the whole high-risk cohort, the observed non-attendance rate was 10.8%. So skewed upwards considerably by the fifth of patients who we couldn't get in touch with and their very high non-attendance rate. So to sum this project up, we reduced non-attendances, which was our primary aim from this, was reducing some of those non-attendances, which is great. We think this is cost saving even after staffing costs. If you work out what Rich said about before, so if you look at the revenue that we would have brought in from the tariff costs from these, we think we've saved more money than it would cost to actually implement this project when you take into account staffing costs and employer national insurance contributions. We believe we've improved the patient experience. Our feedback surveys seem to suggest that people liked the calls. They'd be happy to receive similar calls for other specialties, and they found the calls helpful, useful, and in some cases help put their mind at ease, especially anxiety around this kind of procedure. The benefit was felt as well as observed, so it's not just about the numbers. Our clinical and administrative staff reported reduced downtime during the lifespan of this project relating to non-attendances, because ultimately if someone doesn't attend, it impacts our clinical and administrative staff who've got to sort that out. And so lastly, we would say that this is strong evidence that this approach works. We would fully recommend that if you're thinking about doing something like this, you give it a go, because we think it works. And with that, I will pass back over to Rich.
Thank you.
Hi, that was a brilliant talk. Thank you for giving us that full story and pipeline. What a great piece of work. There's been lots of chat and quite a few questions, so I'm going to share some of those. Mm-hmm. This was a really nice question. So in your opinion, what's the advantage of let me just share now. In your opinion, what's the advantage of a machine learning approach rather than a conventional regression model, given this context?
I'm gonna answer that. I think that's a great question, and I feel it is always an interesting trade-off between maximizing predictive performance or going for a more simple, interpretable approach. Our rationale was we chose the model that among the models we tested, and we did look at regression models as well, logistic and polynomial regression. But the jump in predictive accuracy that we got from using XGBoost instead was, in my judgment, significant enough to justify going to a more complex model. But I generally also find this is a very difficult question that's really hard to answer rigorously, right? Because it's hard to kind of weigh interpretability against predictive performance. But I would like to say I think we try to make up for that by evaluating the model on a bunch of different metrics and for different patient subcohorts, so that I think we understand the model that we produced quite well, and we're quite confident that it works as we expect it to do.
Great, thank you. We have another question, which was sort of about bringing that data back into the model. So once you were sort of calling people, would you then add the sort of number of calls made to then attributes for sort of, you know, future modeling?
No is the short answer. So the patient's previous DNA or attendance history goes in. So whether the patient, if you imagine they had 2 appointments, whether the patient appeared or not at the first one will factor in, but whether we'd previously called them didn't go in. Maybe we should play around with that. To be honest, I hadn't even thought about that.
Yeah, it's a very interesting idea. I also hadn't thought about it. I guess we would have to collect data on how that changes patient behavior with regards to attending or not attending to then, you know, retrain the model on it. But yeah, definitely an interesting suggestion.
Thank you. One more longer question, and then we'll wrap up with some very quick ones. Were there any IG hurdles around, you said when you were actually ringing people, you would ask about if they had any barriers to attending as well. Was there any sort of IG hurdles there with the qualitative data stuff?
I'm happy to take that one. No, we didn't run into any IG hurdles around this. I mean, we've got quite a good IG team who are always happy to give us plenty of advice when we need it. I appreciate. Not everyone might have the benefit of such a large information governance team as we do, but no, I mean that information hasn't been put into PARS. It hasn't been kept. Whether it could be or not would be important for us, I guess, but. That data only lived for the lifespan of the project, and it wasn't kept or stored or associated with the patients long term. So no real IG issues for us there.
It does sound like it was really helpful though in you sort of having that wider context. Really nice to collect that qualitative as you're doing the quantitative.
Yeah.
Fantastic.
Yeah, I mean, aggregating that data, it's really helpful for us to understand some of those barriers to attendance that we've never really recorded information on before. So yeah, really helpful.
Lovely, thank you. And then there have been a couple of sort of questions in the chat just around, is there any plans to sort of roll it out further, and also if the code is available online or if there's any aspects that are sort of open source?
I can handle the rolling out wider one, but coding one, Rich and Fabian, I'd be happy to be you, I'm afraid. So we've currently got an endoscopy navigation program running at the moment. We've actually got 2 endoscopy nurses doing it. It's very unusual to have clinical staff doing this kind of work, but at the moment we've got a bit of spare capacity at one of our sites, so we've got 2 endoscopy nurses who are calling patients, and they're probably about 170, maybe 200 patients through that list at the moment. They've been doing that for about 6 weeks now. So we'll be due to evaluate that in the new year, but we expect it'll have been as successful, if not more successful, given these are clinical navigators, than our project was.
Great, thank you. And yeah, people are very excited about this, and they want to see more.
And yeah, maybe to quickly comment on the open source question. So currently we haven't really thought about that yet, but it's actually a good idea, and I don't see why we shouldn't do that. But we are currently writing a paper about kind of the technical aspects of this project, and I guess maybe as part of that publication, it would make sense to also make the code accessible. So yeah, good suggestion.
It sounds like there would be lots of interest in it from the glowing responses in the chat. So yeah, we'll keep an eye out. And if you want to reach out to the speakers as well, you can use the participants panel to find our Northumbrian friends and drop them a message if you want to sort of continue that conversation. But thank you very much again. That was a brilliant talk.
Thank you.
Thank you.
Thank you.
So
we are kind of in the process of putting together a bit of an information pack about what we did as well. So contact us if you want that. We've not written it yet, but when it's written, we'll send it on.
Yes.
Awesome.
Oh, and
Thank you so
I would
much.
be remiss if I didn't mention that we won a HSJ award for this. I'd be told off by managers if I didn't mention that as well. Yeah, so
you've got the big trophy slide.
Win an award for that one.
Well deserved.
Yeah, thank you.
Okay, so that's the end of the improving flow stream for this morning. Lunch is now until 1:30, not provided. You've got to bring your own sandwiches. Sorry, friends. So the main room is kicking off again at 1:30, and the improving flow stream is starting again at 2:30. So we've got lunch now back in the main room at 1:30, and the improving flow session is starting again at 2:30. So enjoy your break, and we'll see you after lunch.